Hello, welcome and kumusta? My name is Hao and I am your occupational therapist and welcome to my podcast entitled OT Conversations. This is a podcast about occupational therapy and any other topics relating to the field, be it medical foundations or philosophical foundations, some of my personal and professional opinions and point of view. I am hoping that through this podcast, I'll be able to help out occupational therapy students and clinicians to navigate their way through their clinical practice involving occupational therapy.
This episode of OT Conversation was done with my previous guest, Wang. Wang is an occupational therapist who's working in a pediatric facility, and she, like myself, has accumulated a good amount of years working in the field of occupational therapy. Talking earlier on about how things change when you're working after a long period of time, and that there is you're no longer just clinically working in the clinical sense where it is very prescriptive, or it's very what's the word, step by step, where you
Very
feel
textbook.
yes, very textbook, where you feel you're bound to well, you're still bound to rules, but like bound to processes. It just feels like after a period of time, you are now really addressing the real situation. The real situation in the unit. You're looking at the real problems, and your way and method of collaboration with other members of the team is much more real, isn't it? Much more
Supportive and collaborative. And I think as a senior therapist, you start to take on more calculated risk than when you're younger and less experienced. So at this stage, you kind of look into you have an insight to what's going to happen next. And so you can work towards that and have a bit of a leeway on how you can facilitate things. And other therapists as well, it's nice when you have a team that has the same kind of level of experience, so you can discuss things in a very mature way.
I see what you mean.
Yeah, and you don't limit yourself. It's more like a can-do attitude, which is nice.
It's a can-do attitude when you're working at a level that is more on a senior level, not in an authority way, but
No.
when you have an experience, isn't it?
It's not authoritative at all, because they know way we all know when you think this no, or you're wrong, and it's not what do you call this, appropriate for the situation. But you also know, and we all respect each other's decision and try and work towards one goal for the patients that we see. It's like this patient that wanted a spinal cord injury, 14 years old. He's very
So the spinal cord injury patient that you have is 14 years old.
very tall, very
Tall,
good,
active,
yeah,
good looking.
good looking, big build, and also very strong in the upper body.
So spinal cord injury, what level was it?
T9.
T9, so thoracic. So
T9 motor looks T9 complete motor.
is it? And they're aware of it.
Sensory partial.
Sensory partial, motor complete.
Yeah.
Okay.
And they're now aware of it. Initially, they were still hopeful that that'd be something that they can do, medically can be done. But I think we're gearing towards this is it really. But there's rehab, referral to a specialist facility.
There's still a referral.
Yeah, and I think it's likely to be accepted. We had a meeting with the facility, and he's on a list.
So this would have been a pediatric rehab facility for spinal cord injury?
Well, it's not. Well, there's no pediatric rehab facility in the UK.
For-
That's specific. Well, there's a few beds in one of the centers for pediatric, but
Well, for spinal cord injury.
it's
So
not.
is it Stoke Mandeville?
Yeah.
Yeah, pediatric, which would have
No.
been
Yeah, they accept pediatric, but there's not a lot of beds for peds.
which would have been from 16 below, is it? Okay.
16? Yeah, 16 below. And it's still gonna be a wait, but the thing is, he's medically, optimized, and he needs to go.
He's stable.
He wants to go home.
He wants to go home. So this person at the moment is actually in a hospital.
Yeah.
You are working with him. I imagine he would have been in the hospital for quite some time now. How, 6 months, 3 months?
No, not that long. I think it's just a few weeks.
Few weeks only.
Yeah, few weeks.
Okay.
He
weeks?
just, I don't think even. Yeah, not that long. But he had a course of treatment, and there were. I don't want to go into much detail about the diagnosis, and
But is it an accidental?
no,
I see.
no, it's not accidental. So there's a history of.
So there's a medical problem that caused it, rather than.
Well, there were lots of investigations. Is it spinal stroke? Is it transverse myelitis? Is it infections, inflammatory? Because it just suddenly happened.
Mm-hmm.
It suddenly happened that he started losing control on the lower half,
Okay.
and he, until to a point that he couldn't walk, and he just dropped. So he was rushed to hospital, had a course of treatment, and there's so many teams involved. It's not neuro. I'm part of the neuro team, but there's also the what team is that?
Can't be orthopedics.
Oncology.
Okay.
There's also that.
Okay.
But I go through across anyway those specialities, so that's fine. There's no other OT took over, but so that's where he is medically now.
Okay.
He wants to go on a weekend leave at least to try how it's like to go home.
Mm-hmm.
So and it's a good thing with our facility that we're allowing children to do that.
Mm-hmm.
We save the bed for the
Keep the bed. Let them try going home.
and then come back.
Yeah.
And any concerns, we can still manage it. We can still do something about it before we fully discharge home.
Mm-hmm. So what about the risks? What you were talking about the risks earlier on.
Right, yeah. So because it's a sudden, he's already known to me, and I've been starting communicating with the team. So even before there's a plan for going home, and he's still very medical. I started talking to referring to community team, referring to wheelchair services, so they have a heads up. Now, if once there is a go ahead to go home, then they're aware and they can help. So this week suddenly they just decided to remove the Vascath, and then he's medically ready anytime.
Vascat.
The big lines.
vascular cat.
Because he had the plasma exchange, so just to clear out everything and see if
Plasmapheresis, yeah.
and then what happened? So the parents were asking if they can go home this weekend. So this happened just this week. That's just Tuesday. And we didn't have any equipment yet.
Mm-hmm.
So what do we need?
So to try going home, we're trying to establish what do we need and some of the equipment. So what equipment do you have in mind?
And since I'm physios are very actively involved with his rehab, so they're really doing strengthening and all mobility and transfers. At the moment, he transfers with a
Sliding
transfer
board.
A sliding board.
But that's a compensatory method, isn't it? So strategy, which means the rehabilitation is a functional rehab, meaning the person needed to do the things.
But he can, if so functionally, he can he can dress himself. He can
Now,
he can do
in a
most
modified
of-
way.
Yeah, in a modified way. He's very good problem solving and finding ways on how he can do things differently.
Mm.
We talked about it, and he's already making plans of how he's going upstairs
Mm.
at home.
Really?
Yeah.
Going up in his bottom.
Yeah, going some bottom.
I know
I said
that.
I
I knew
can do
that.
this
I can
and do
predict
that.
that.
So really downstairs. Temporarily this weekend, they agreed it's gonna be downstairs, but they will. I have no doubt they will try going upstairs.
Are there any potential slight movement on the legs at all?
No,
There's none.
no, there's
No
motor.
movement. But
Uh,
there's feeling.
There's some feeling. It's a partial sensory. So from T9 level, it doesn't have bowel control. He's no bowel bladder control. He can't, contract his tummy. So although he can sit unsupported. It's still very difficult for him once he goes he lean forwards on an angle of about 30-40 degrees. He loses control, and that's scary.
Doesn't have balance.
Yeah, but he
Excuse me.
can keep himself upright.
He cannot.
He can.
He can. If it is upright, but
He's
leaning
upright.
forward.
Leaning forward is a bit scary. He can't do that. It's just he has to be holding on. He's using
Yeah,
his
he has
hand
to
because
compensate.
he can't move his legs. So that's one thing that he's worried about. Can't contract his tummy. So this weekend, what we decided is to have a commode for at least near the couch. There's a mobile commode, so it's easy to roll him, push him to the toilet, and it would fit the toilet downstairs. I didn't need to do a home visit for this. It was because it was all rushed. So I got the dad to do the measurements. for
So
me.
would you have chosen, if it was a standardized thing, would you have chosen to do an access visit if you were given time?
If I'm doubtful that the parents or him will not provide me an accurate picture of how things are gonna be at home, I would have.
Yeah.
But analyzing the situation, the information they provided, how engaged they were, how engaged he is, and looking at it or everything he's doing at the moment, I don't need to.
And that was the risk that you were talking
Yeah,
about,
this
isn't
is
it?
what you call the calculated risk you're taking, and it's not just me; it's the whole team as well. They can vouch for it, and we can see it. He can. I got pictures of the home, and also the community OT I've been in contact with them already, and they're going to follow up.
Right.
So there is that collaboration already happening. So technically, as an acute therapist, I could, but if I can work without doing that and having someone else that's more kind of be long term working with him, I don't need to really.
So the risk is this, the person is trying to plan, you guys are planning to do an access visit, and everybody agreed that this needed to happen, and everybody is working towards this, including the multidisciplinary team. So it's not just your call, everybody is really working on this. And you have made decision that he can go based on the information that you have obtained, where family was providing the information, and because you were pleased about the information that they were providing, because you have confidence in the situation, that what the family was providing was reliable. So you had to forgo of the actual access visit, which is very good. And in some ways, it comes with experience, the confidence of doing that.
Looking back, if I was younger, I wouldn't.
Yeah.
I would have gone out. No.
You wouldn't let that happen, won't
I
you?
will go out. I'll do my measurements. I'll see you there. So many things that I want to look into
Yeah.
before I send you home.
Exactly.
And I wouldn't have let you go without a bed downstairs. But then, parents, first they don't. It's only weekend, and he might not even stay downstairs. And it's for them. It's a waste of
Time, resources.
and space.
It's very impractical to do
Yeah.
those things at the moment.
But if you go by the book, you would need a bed.
Mhm.
You need a commode.
Yeah.
It has to be high-low. It has to be level. But I know this is really tricky because he is a strong boy.
Oh, yeah?
Upper body, he could carry you.
Would he?
Yeah.
Okay.
That's how strong he is. Car transfers, he's already thinking he'll swing through the car.
He'll swing it. And it's acceptable, isn't it?
Yeah.
It's an acceptable risk because you have worked with the client and the family and it is doable, isn't it? So potentially for the time being, try weekend is the plan. They
Yeah.
have made recommendations themselves that they might try sleeping on the couch. And that is doable for those aspects where it's difficult to do slide transfers because of an unlevel or the surfaces are not level, say from a commode to a chair. That's the father would help. So they have accommodated for those situations, and it is a risk that is there, but it is accepted and it's acknowledged where there'd be once there are problems, there'd be no blame, isn't it? And I think why there's not going to be any blame is because it's a proper collaborative working, isn't it?
It is you're working with them.
Yeah.
And they're working with you. And
Yeah.
it's not, you're not just dictating what
Yeah.
you want them to do at home.
Yeah.
Because they'll be the experts in that area. That's their home, that's their son. And they know you're there to support. Because we have the knowledge of his medical needs. And we can just put them all together and make a plan together. And I think that makes discharge better. Makes our
Right.
discharge planning better. And we gave them the option of the bed. But they just, at the moment, they said, let's keep it simple.
Okay.
Which is so true. It's just a weekend. We're not going yet.
Okay.
If in the weekend we think that's really going to be an issue on the long term, then we'll let you know. And that's perfect. Said, yeah, okay, I'll see you again on Monday. See how you get on, and then we can.
So when were they going? They were going on a Friday or
They're going now, so they were left yesterday
Okay.
and coming back on Sunday.
So they were going on a Saturday and then we'll be coming back on potentially on a
Where
Sunday.
are we now?
Okay, we're not dictating dates and time.
Okay.
So it's a proper case. So at some point, at some time, it's gonna happen. It's a trial discharge. So I think once this is published, this would have the event would have taken probably, you don't know, guys. It's probably gonna be 6 months down the line, or the situation has happened. But we're sure to follow this up. At the moment, we're talking about calculated risk. I think the theme of this discussion is about calculated risk, and the risks as you get more clinically mature, you get to accept those risks and you're happy to take on those risks because you're acknowledging that everybody in the team, and that includes the parents and the person, the clients, they are part of the people making the decisions, and they have been planning all of the what do you call this, the solutions to potential problems, isn't it? Yeah. Okay. I mean, from my situation, I have just recently had a case as well, and the person is a grown-up man, had an operation as well, and in the morning, our rehab assistant has had wash and dress practice with this guy, and he managed to do it. He showered on his own, he got changed, he got dressed. he's walking with a walking frame, and he was so keen to go home. And but I just needed to go and see this guy at the end of the day, just to finalize everything else, just to find out, just to check what was happening. And then when I came in to see him, he was just upset for that, for some reason he was not being allowed to go home, because he only managed 2 step ups, on their stair simulation, with the rehab or the physio assistant, and he wasn't pleased. And then, and he was really almost, you can look into him, and he was really shaking, trying to control his temper, and couldn't see the reason why he could not be allowed to go home. So I explored the situation with him, and he said that he's had some knee operations in the past, and he was having some difficulty already. And then he said that if it takes him time to go upstairs, he'll pace himself. He'll stand up on 2 steps and then wait and then do it again. But in himself, he was very confident that he is good to go, and he really wanted to leave the hospital. And so the doctors, the surgeon was happy, the nurses were happy. Functionally, he was good. And I was happy because he's actually doing good, and he has the capacity to make these decisions. And then the only thing that's different there is that clinically, the recommendation of one of the members of the team, which would have been the physiotherapy team, was that they were asking for 2 more days for the client to stay,
To try the stairs.
so that he can do the full flight of stairs. And this is just really, the person was just not really happy about this.
Can he not stay downstairs?
Well, he could make that decision to stay downstairs, but the
But
client
he
does.
can walk.
He
so
can walk.
He can walk. It's
Yeah.
just the stamina, is it? To
No,
get
no,
upstairs?
it's not
What's-
even that. He's just slow because of the knee problem, and maybe because he was
Oh,
having
it's a knee
difficulty.
problem.
He had a history of knee replacement. Yeah. So his argument was that going up and down the stairs has never been easy anyway. It's always been difficult. So this guy had a thoracic surgery, a form of thoracic surgery. So if it was the case, you would be worried about, the breathlessness or the heart rate or
not
the
the knee.
stamina and the endurance. Yeah. But not the knee, isn't
It's
it?
the knee that's pre-admission.
Yeah.
That's all been there.
So-
that's
Yeah, so this guy, he did not manage to do the stairs, but the reason is not because of the chest and the stamina issue. The issue is because of the physical reason that it was difficult,
so then
and they only managed to do 2 steps. And the physio was arguing that, and negotiating to at least have 2 more days, with the hope that it would improve. Yeah, with the hope that it would improve, because they didn't get to do it the first time. We don't know whether they didn't push it hard enough, or they were rushing the session. But ideally, so you take note of the problem. So the reason why they were admitted is because of a form of a surgery on the thoracic region. So really, the cause of the stair problem shouldn't
be related to that.
be related to the cause of the actual problem, which is coming from a biomechanical issue, isn't it? Unless he was admitted for the knee operation, then yes, isn't it? So that was the situation, and the what I did, it just happened that this senior clinician, senior physiotherapist, walked by, and so I raised the concern in the situation. So I didn't mention the case, and as soon as I mentioned it, the case at the very beginning, from the very beginning, I told her the story of where we're at and what our issues. It's like straight away the physio says, yes, go, send him home. That was fine.
Yeah.
Which reflects what we were talking about the clinical maturity, where you accept the risk, and you accept the risk because you are in collaboration with the client. The client is a big part of the team and a big part of the your decision making. And so I did mention that to the client. He was so pleased that he was going home. Now, after that, when we went back to the office, the clinician, the clinician who was asking for 2 more days, approached me and said, were you really happy? And I know she wasn't pleased because her decision was overridden. And I think that's another conversation on another part of the day, and I'd like to have a good conversation with her, just so that she can factor in the things that we talked about now. She, and I understand, as a young clinician, really, being a new clinician, you really wanted to go by the book, isn't it? You don't want to break the rules.
No, it's because the reasoning is backed up by that. At the moment, that's where you're getting the backup for what your decisions are. Whereas if you have that vast experience already, you can connect all those situations in the past and use that as an evidence that this could actually work, and this is fine. It's fine to do that. You can already anticipate what's going to happen next, sort of, and you have that emotional and professional maturity as you get to that level of experience. I think that's why. And as a young clinician, you don't have anything to back you up but the book, really, and the guidelines. So you kind of stick to that. And we've been through that too.
Yeah.
And it's a tricky stage because you want to prove yourself. And at the same time, you want to be sure that this is safe to do. How is this safe if you've not seen it? That kind of question.
Yes.
I've not seen it. I've not seen you transfer. Can you do it? I don't want to do it now, but I have to see it, So that those stages.
I hear that regularly, with younger clinicians, with people I'm working with. It's like, well, can they go and put on their bottom-up clothing? I don't know. I haven't seen it.
Yeah, which is no.
Yeah, you have to analyze it, isn't
Analyze
it?
the movement. Analyze when you're talking. You don't. Like the other day, one of my patients, she's still asleep. She's just on the bed, and I went in, and the therapist was supposed to be a joint, and I said, "Oh, we can't do a session. She's asleep, but the dad's awake." So I thought, is it okay, Dad, if I stay, just have a little chat, and while I'm observing her sleeping, which is, I said, yeah, sure. And we were talking, and I can see her moving her arm. She's very dense on the left. She can't move her left, but I can see the right arm moving everywhere, and the left leg and the right leg on a frog position, and then she moves her head. She's just so I'm observing her already while she's sleeping, and that's my assessment.
And you were doing an assessment.
And I was doing an assessment while talking to Dad. And I got so many information from that 30 minutes talking to Dad.
Just talking to that is amazing.
Yeah, it was really...
So it's well, as you get more mature and more of an expert, you become a super therapist. You manage to make an assessment when the person is asleep. Whoa!
It's not full assessment, but I managed to get so much out of it.
Yeah.
It's that 30-minute session that is precious, because you see a lot when the child's asleep too. It's a normal kind of movements. It's not anticipated. They just you see the normal positioning, the relaxed positioning.
Yeah. So the symmetry.
You can because this child's 3-year-old diagnosed with
still
stroke.
young.
Yeah, stroke, and they're saying it's hemi on the left, but they're not sure of the movement. If there's movement, there's no movement. But you can see there's just no movement while asleep. But the right side, the positioning, the posturing of the other half is very normal. The tone is, you can tell from how it looks like that the tone is there, that there's normal tone, whereas the left is completely flat and flaccid. and
I see. So it's more of a. So you didn't need to assess. Again, there's a few factors here. So
there
the person.
will be an assessment to
Yeah,
follow.
yeah.
There'll be like an awake
Yeah.
awake session,
Yeah.
but that's a sleep session. And
Yeah.
and really, my plan was just to talk to Dad and
Yeah.
gather information, how she was before, what things are already in place.
Yeah.
Was there any and that in that moment, I also found out that she's already known to community team because of other things, and she has some equipment already. She's using this, she's doing that. She can do this and that before this, and I got the number of the community OT. Already spoke to the community OT after that, and she's and they already know her, so from that that already saved me the referral that I was supposed to do, you know. That saves me time. So that's how quick the process. 30
You can
minutes.
do it.
30-minute session. Child's asleep. There's no reason not to do anything. And there's no reason not to do anything.
Exactly. That's what I've just been saying to people as well, you know. You just need to be there. Isn't it? You can do things, you just need to be there. It's just like a relationship, you know. You don't have to do anything, you just gotta be there.
Yeah. Establishing rapport, it starts there as a OT process, isn't it? With the parents for us. I don't know with the adult, of course. I don't know. I mean, it's different.
You're right. And there's a few factors I was telling earlier on with that particular case and scenario that you had shown. One of the scenario there was, one, the child is a child, it's a young child. So when the person was asleep, your assessment on the physical ability of the child, you managed to do that simply by observing the postural alignment. And you're able to tell that one is dysfunctional or functional based on the posture because you're aware of the pathological or impaired posturing. You know, when somebody has had like hemiplegia, for example, like what you said, like a frog position, flaccid, as compared to the other one where it's more aligned. I'm sure you've seen that the shoulder, the scapula, the arm, you know, was more moving. Like the tone, you can just observe that even without examination. You know, and there should be symmetrical. It's asymmetry, isn't it? There was asymmetry there, and just by that, on that alone, you can see.
You can see where the head is leaning. And then I asked her, is she normally like this? No, she would. No, before this, she could bring her head to the middle and stay on the other side. But since she's been like this, it's always on this side.
On the one side,
on the
yeah.
one side, and then the dad man she showed me. Oh, I think her left is painful. How did you know that? Well, look, and he touched the left leg, and she winced and started crying. So there is some sensory issue which no one can tell. No one has seen because she's always awake when someone's visiting.
Wow! So you touched the leg.
Touched the leg.
The child, actually, the dad touched the leg.
Yeah, that touched the leg.
She winced, and you're already suspecting paresthesia in there.
Yeah.
Hypersensitivity.
Exactly.
You know.
Exactly. Whereas I said, can you touch the other leg? So I've been asking the dad, not me, so she doesn't get angry at me. So I'm establishing rapport with the child too.
So the child was asleep?
Yeah, well, in and
Partly.
out of sleep.
I see,
She's
okay.
in and out of sleep. We tried waking her up, so I think that was my plan too. If she fully wakes up, then we can continue with the assessment. And then Dad touched the other side, and she didn't care. She was fine and just carried on sleeping.
See?
So and then at the other side again, and then
And they were crying. Yeah, she was
so
crying.
there's
And
paresthesia.
apart from the physical observation based on that, you know, I think as occupational therapists, we always assess, look at the bigger picture, isn't it? What's the situation at home? Where are we? What's happening? And based on that, you manage to find, to establish from the dad what the home setup is, where, you know, you manage to find out the support services already. Wow, there's so many things, isn't it?
So many things. It's like opening a door that is not in the hospital. It's a completely different perspective of what you see on the bed. So this child's doing this, she has some conditions already, she has some delay before this, but she was beginning to be more independent to walk. She used to have a walker.
Was it cerebral palsy?
And now Dance, so she has trisomy 21.
Trisomy 21.
So she's delayed already, but she's been
see.
been very hypermobile. She wears a lycra suit. She has a physio and OT in the community. She goes to special school. So there's so many things, but then knowing the home situation, like there are four of them, and they only have they have one bedroom flat, which is in the first floor. So it means she needs to access a flight of stairs. Although she's
At
still
some point,
she's still little, she can
be carried. Yeah.
But equipment wise, if she'll be needing specialist buggy, specialist seating, that's hard to get to the upstairs. There's no lift in the facility. It can't be left downstairs. And she has she needs some kind of postural support now. And at her age, 3 years old, you need some kind of specialist seating for the children to be able to engage in most activities. So that is a situation for the community team. But you're already looking into that as well.
Right. So the client's already got some genetic problems, like trisomy 21, as you said, trisomy 21, and that was the reason why she was known to, or the child was known to the community team.
This is a new illness,
and now it's a new
sudden,
problem,
and
in
it's so
to.
in addition to it.
Yeah. Okay. All right. Okay. Well, that's good. That's good.
And looking at her looking at her on the bed, where her leg was actually very, very abducted to her side. That is it's just a sign of her hypermobility.
It is hypermobility, isn't it?
Which is part of the trisomy 21.
Yeah.
But if you don't know that, you'll be like, wow, that looks like dislocated.
Yeah. So you should be. Okay. Now, wow, I think that's a very, very wonderful discussion, isn't it? So we've talked about taking risks, about the, like controlled risks, associating clients, and taking clients as part of our decision making. Collaborative working, almost like activity analysis, being involved as early as possible, and the value of experience. So do we have any advice to any younger clinicians then? Or, I mean, not younger, new clinicians or emerging clinicians about this? How would they go about with it?
If in doubt, consult with your seniors.
Yes.
Um,
Get the wisdom.
yeah.
Learn wisdom from those people who have had more experience, isn't it? Run the case over with them if you have, and it would have been nice if you have. Run the case over with them, but make sure, from my experience anyway, make sure that you've done what you can anyway first. You've learned a lot. You've established enough information about the case and about the situation. You should have done your homework first, you should have done the establishing the baseline. What is the situation? What are the scientific merits of the case? What's the narrative merits of the case? What are the pragmatic merits of the case? And then once you have all of those information, then you can go to your senior support, and you can run the case over so that you can make a decision together, isn't it?
And also really listen to your clients, because they have the insight to their home situation, which you can't see.
Yeah.
And don't dismiss.
And factor that in. That's what I meant about looking at the narrative case, on the clinical reasoning. So scientific being everything about the case, narrative being about everything about the clients, isn't it? Yeah. And I think you have, as a young clinician, and for those of you who are listening, they really need to try and do some things first. Because from my experience, what I'm getting is that they see the case, it's complicated, they don't even want to push themselves forward. They see the case, like for example, spinal cord injury. Oh, I don't know this. I have not had any situations
Then
like
you're
this before.
limiting yourself
Then
already.
already I can't do this. I am so stressed already. I was like, oh my God, I can't do this, and that's it, that's it. And you can't do anything. You can't learn. You're not going to grow, isn't it?
As senior therapists, we're still learning. It's not that we're experts already. We know the situation, but we're still learning every time. So we're still also taking risks all the time. But as young clinicians, don't be what do you call this,
Confined.
or don't be stopped by situations that you don't know.
Yeah.
Seek
I-
advice,
seek
seek
ad-
support,
Learn about it.
learn.
Continue learning. Yeah. Again, this is again a repeating scenario, young clinicians, obviously without a lot of experience yet, but as soon as they see a case that they didn't have any understanding, they are so quick. People are so quick to back out. And it doesn't help them professionally, because you don't grow. All right, shall we conclude this?
Yeah.
Is this a very good conversation?
Okay.
Is this a good conversation?
Yeah.
It is a good conversation. So, my name is Hao, and I am with Wang, and this is OT Conversations.
Bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. I am but your humble clinician, albeit with years of experience, I have very little understanding of this digital world. So if you have any questions or if you have topics that you want me to talk about, drop me an email. It's riot.conversations@gmail.com. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.